High-yield medical MCQs, musculoskeletal and peripheral nerve injuries.
A young patient had an ankle sprain following a hit with a stone while running. On arriving in the emergency department, which of the following is not included in the initial management?
All right, are we looking at A, protection, B, rest, C, hanging foot down from bed, D, compression, or E, ice therapy? And the correct answer here is C, hanging the foot down from the bed. You see, the initial management of acute soft tissue injuries relies heavily on the Price framework. If you hang that foot down, you're actually increasing hydrostatic pressure. This immediately exacerbates local edema, swelling, and that awful throbbing pain in the affected joint.
So let's lock in these exam pearls. The Price protocol is literally the gold standard conservative strategy for acute non-operative sports injuries. Crucially, when we say elevation, that extremity must be kept above the level of the heart to properly optimize venous and lymphatic drainage. And don't forget, proper application of cold therapy causes vasoconstriction, which minimizes localized hemorrhage and inflammatory exudate.
All of the following are causes of limb length inequality in the hip except.
Your options are A, rheumatoid arthritis, B, osteoarthritis, C, hip dysplasia, D, hip fracture, or E, hip dislocation. The correct choice is A, rheumatoid arthritis. Now why is that? Well, rheumatoid arthritis is an inflammatory, systemic, autoimmune disease. It characteristically causes symmetric joint space narrowing and uniform cartilage destruction. Because of this symmetry, it actually prevents true structural limb length discrepancies early on in the disease process. For your exams, remember that true structural limb length discrepancies are caused by actual structural skeletal disruptions. Think advanced osteoarthritis, femoral neck fractures, or DDH. Apparent leg length discrepancy, on the other hand, happens from pelvic obliquity or joint contractures without any structural bony shortening. Meanwhile, osteoarthritis of the hip typically leads to asymmetric superior joint space narrowing, and yeah, that absolutely causes structural shortening over time.
High-stepping gait is seen in which of the following?
Is it A, cerebral palsy, B, hip joint arthritis, C, gluteal paralysis, D, palsy of common peroneal nerve, or E, palsy of sciatic nerve? The answer is D, palsy of the common peroneal nerve. This nerve palsy paralyzes the muscles of the anterior leg compartment, leading to a complete loss of foot dorsiflexion. We all know this as foot drop. Because of this, the patient literally has to flex their hip and knee excessively just to lift their foot clear off the ground during the swing phase of walking. It's a pure mechanical compensation.
Let's review these classic gait patterns. Common peroneal nerve injury presents with that classic foot drop and the high-stepping gait we just talked about. An altalgic gait is simply pain-avoiding, defined by a much shorter stance phase on the affected limb, which you'll often see in hip joint arthritis. And then you've got the Trendelenburg gait, caused by weakness or paralysis of the hip abductors, specifically the gluteus medius and minimus, resulting from superior gluteal nerve pathology.
A 31-year-old male presents with shoulder trauma after a fall from a bike. The right shoulder is tender and movement is impossible. Which type of shoulder dislocation is most common? A, anterior, B, posterior, C, superior, D, lateral, or E, medial? The answer here is A, anterior. Traumatic anterior, specifically anteroinferior, shoulder dislocations account for over 90% of cases. The exact reason? It's a structural lack of complete reinforcement from the rotator cuff muscles at the anteroinferior aspect of the joint capsule. So the rotator cuff doesn't completely reinforce that anteroinferior capsule, leaving it incredibly vulnerable. This dislocation almost always occurs when a traumatic force is applied to an arm fixed in abduction and external rotation. And for a first-time uncomplicated acute traumatic shoulder dislocation, closed reduction is your absolute standard clinical intervention.
A 50-year-old female post-mastectomy complains of her scapula becoming prominent on shoulder protraction. Which of the following is consistent with injury to the long thoracic nerve?
Is it A, loss of adduction of shoulder, B, wrist drop, C, winging of scapula, D, claw hand, or E, sensory loss over deltoid? It's C, winging of the scapula. The long thoracic nerve directly supplies the serratus anterior muscle, and that muscle is what stabilizes and anchors the medial border of the scapula against the posterior thoracic wall. If you paralyze it, the scapula completely loses its anchor and just protrudes outward.
Keep in mind, the long thoracic nerve is highly vulnerable to traction or transection injury during axillary lymph node dissection and modified radical mastectomies. The classic clinical presentation is winging of the scapula, which becomes incredibly obvious during a serratus wall push test. Functionally, this paralysis of the serratus anterior severely limits the patient's ability to perform overhead arm abduction beyond 100 degrees from the horizontal plane.
A patient presents with wrist drop following trauma. Exploration reveals intact epineurium and perineurium with absolutely no degenerative changes. Which type of nerve injury is this? A. Neuropraxia. B. Axonotmesis type I. C. Axonotmesis type 2. D. Axonotmesis type 3. Or E. Neuromatesis. The correct diagnosis is A. Neuropraxia. This condition is explicitly characterized by a focal conduction block secondary to localized myelin injury. It completely preserves the structural integrity of the nerve connective tissue sheaths, specifically the epineurium and perineurium, and there is a distinct absence of distal Wöhlerian degeneration.
Looking at Seddon's classification of nerve injuries, neuropraxia carries an excellent spontaneous recovery profile once the pressure is relieved. Contrast this with axonotomesis. That features actual axonal discontinuity and downstream Wöhlerian degeneration, but it still maintains those intact connective sheaths, meaning it regenerates slowly at about 1 millimeter per day. Neurotomesis is the complete structural division of both the axons and all surrounding layers, carrying a very poor prognosis.
A 32-year-old female presents with a nighttime tingling sensation in her hand, relieved by shaking. Sensory deficit is present on the volar aspect of the thumb, index, middle, and radial half of the ring finger. What is your probable diagnosis?
A. Ankylosing spondylitis. B. Cervical spine arthritis. C. Temporal arteritis. D. Cervical spine dislocation. Or E. Carpal tunnel syndrome. It's E. Carpal tunnel syndrome. This is definitively caused by compression of the median nerve exactly as it travels beneath the transverse carpal ligament. This anatomical pinch point perfectly explains those classic nocturnal paresthesias and the highly specific digital distribution map we just outlined.
A massive diagnostic exam pearl here is sensory sparing of the palm. Sensation over the central palm remains completely normal in carpal tunnel syndrome because the palmar cutaneous branch of the median nerve arises proximal to and passes superficial to the carpal tunnel. You evaluate this clinically via Phelan's test, Tinel's sign, and Durkin's compression test. Severe chronic median nerve entrapment will eventually yield visible wasting and thenar atrophy.
A patient presents with a complaint of wrist drop. Sensory examination reveals loss of cutaneous sensation over the lateral and posterior arm, posterior forearm, and the lateral half of the dorsum of the hand and digits. What is the most likely diagnosis?
Is it A. Radial nerve injury in axilla, B. Radial nerve injury at forearm, C. Radial nerve injury at wrist, D. Median nerve injury at wrist, or E. Ulnar nerve injury at elbow? The correct diagnosis is A. Radial nerve injury in the axilla. A high-level radial nerve lesion right within the axilla destroys absolutely all downstream motor and sensory branches. This massive deficit manifests as a complete loss of triceps function, meaning a complete loss of elbow extension, along with full wrist drop and those extensive cutaneous sensory deficits.
So an axilla injury, famously known as Saturday night palsy, paralyzes the triceps and causes severe wrist drop. Drop down to the radial groove, like in a mid-shaft humerus fracture, and you get complete wrist drop, but triceps function and elbow extension are weakened yet functionally preserved. Go lower to a posterior interosseous nerve injury, and true wrist drop does not occur because the extensor carpi radialis longus is completely spared. So here's something to think about as we wrap up this explainer. If the triceps is spared, are you dealing with a groove or an axilla injury? Master this, and you master the upper lip.